Hi, everyone who is attending this wonderful, wonderful event. It is amazing to be back to do it again. It is Bias in Women's Health as part of Science Week. And we are welcoming you along to look at women's health, inequality in women's health and research. And it is all supported and developed by the RCSI Rotunda Research Department and funded by the SFI. We have a seriously impressive panel of women for you to meet today and to enjoy their talks. And we're going to have each speaker speak for a few moments, and then we'll have a Q&A afterwards as well. You'll have access to their slides and see what they're speaking about. And then, of course, we are going to be able to accept questions from you guys who are watching virtually as well. I'm Alison Curtis, and I am delighted to be here again this year. Last year was a massive success, and I think it very much drove forward the agenda of looking at women's health, bias in women's health, how we can improve health on all levels for women at all stages of their life. And we've got, as I say, a seriously impressive panel, and we are going to be here until 12:30. We've got Dr. Geraldine Connolly from the Rotunda Hospital and Temple Street Hospital. I'm very interested in what she has to say. And I think she has made some serious inroads in looking at young women's health and how we can care for ourselves better. Dr. Nóirín from CervicalCheck will be joining us as well. We've got Loretta Dignam from the Menopause Hub. She founded this, and it's another topic that I'm very interested in, and I think a lot of people are, discussing it more publicly, of course. Dr. Rhona Gaynor as well from Women's Health Taskforce, and then we have Alana Ryan from the National Women's Council of Ireland. And again, I'll remind you as we go along how you can send in your questions and how you can get involved. And as always, you can find out more bias-women-health.com. And I'm sure you already know, but on Twitter and Instagram at @biaswomen'shealth and hashtag #biaswomen'shealth. And I hope you enjoy the next hour and a half. Our first speaker this morning is Dr. Geraldine Connolly, and we'd like to get her to join us now and to start her presentation. And I'm very much looking forward to it. Geraldine, thank you so much.
Thank you very much. So yes, I'm Geraldine Connolly. I work in the Rotunda and in Temple Street. And I set up the adolescent and pediatric gynecology service about 17 years ago now. So I've been dealing with adolescents and young girls for quite some time. And over the years, I have learned so much in terms of what concerns young women. And my sense at the moment is that really a lot of what we need is a lot of education around the whole femaleness and the female anatomy. So today we're jumping straight in here and we're going to talk about the vulva. So there are some diagrams. There is some artwork. So just a bit of a, just to be aware that that's what's coming up on the screens shortly. So we're really not familiar with the anatomy of the vulva, and vulva and vagina are actually used interchangeably, which actually speaks to a real lack of knowledge about our own female anatomy. Unfortunately, a lot of girls and women get their knowledge about what female anatomy is from actually looking at porn. Or from looking at pictures or for looking at movies. So that gives a very abnormal idea as to what a normal vulva should appear as. It's a bit like, looking at beautiful faces on the various magazines and wondering why you don't look like that. Well, because we're all kind of different, and all our faces are different, all our hands and our feet are different, our vulvas are different, and particularly in the younger group that I would be used to dealing with, there's a huge anxiety about looking different in all ways, and also that has now included in the vulva. So there's a lot of misinformation. There's a lot of lack of knowledge about appearance, about sensation, about smell. leading to anxiety, not fitting in, concerns, fear that I'm not normal. And this is all, it's really become really quite a big issue. We have the next slide. So Holly, if we could have the next slide, that would be great. Thank you. So there's a wonderful association called the BritSPAG Association. It's a bit of a mouthful. Brit is obviously British. SPAG is S is the society, and PAG is Pediatric and Adolescent Gynecology. And it is a wonderful subspecialty, really, that has been set up in the UK for pediatric and adolescent gynecology. And there was some artwork developed around this whole, what does a vulva look like anyway? You know, I would talk to a lot of young ladies, younger adolescents, I should say, and say, you know, have a look at this website, because I think this is really interesting, because you can just see from the pictures here that labia are all very different. They can be larger or smaller, asymmetrical. They can have difference in color, and there's just a huge variation, as there is with a huge variation in faces, in breasts, in hands and feet. There's often a little bit of labial asymmetry, again, like there can be in the rest of our bodies. Obviously, a lot of women, or a lot of people, will have one foot slightly bigger than the other, and maybe one breast slightly bigger than the other, and maybe one labia slightly bigger than the other. But BritSPAG is a wonderful resource which is available online, and does have leaflets and information stuff for the public. Next slide, please. So this is art. This is a plaster cast. Wall of Vagina is what it's actually called, and it was started back in 2008 by an artist called Jamie McCartney, who's a man. He actually also has done some of a similar type of artwork with male genitalia. And what actually has really jumps out at me about this whole thing is that it's called the Wall of Vagina. And I know that that's paraphrasing, or it's called the Great Wall of Vagina. And that's paraphrasing the Great Wall of China. But actually, this is not a wall of vaginas, it's a wall of vulvas. So I think this actually really gets to the confusion that there is around genitalia. So on our next slide, please. I'm going to just very briefly go through what all of these areas are. Is there any way I can point here, I wonder? I don't know. Anyway, let's see. So at the top, we have the mons pubis. So this is the area, it's a fat pad actually, that sits over our pubic bone to protect it. And it is a hair-bearing area. Down underneath that, we have the clitoris. So we have two parts of the clitoris, like the prepuce, or it's the hood of the clitoris, which protects the glands of the clitoris. And the glands of the clitoris is really where we get orgasm from. And it is a super, super sensitive piece of tissue with millions and millions of nerve endings. And it's really just, you know, we really just need to know a little bit about what works for us in terms of our sexuality. And I think really, it is really a good idea to be able to know what we look like in order to be able to access our sexuality. Around the opening of the vagina, which we can see, is the labia. These are the labia minora, and these, as I was saying, can come in all sorts of shapes and sizes. They can be larger than the labia majora, which are the hair-bearing areas which surround that whole entrance to the vagina. The labia minora are important. They are sensitive. They are involved in sexual arousal. They protect the vagina, yeah, they protect the vagina. And basically, surgery on this area, we really would have, some of us anyway, would have a significant issue with, and we will talk about that in a little bit. We'll have the next slide, please. So again, what does a normal vulva look like? So pubic hair, you know, is actually there for a purpose. There is a sense of protection. There is some sensation around that vulval area. Often it completely variable. Some people may not have very much. Some people may have quite a lot. It can extend around the back. It can extend onto thighs. There's a lot of issues now with shaving and removing and waxing and lasering. And it's just really, really important to be very careful about how we go about this, if this is what we want to do, because unfortunately, when we do it ourselves, I would see a lot of young ladies, a lot of young women with issues around the skin, with ingrown hairs, with folliculitis, with bad rashes, with irritations, and you know, 1 or 2 people have actually gotten really quite sick with sepsis as a result of a boil that has become really, really bad. So we just do need to be very careful about this. If we want to do something at home, my advice would be just to trim it, or else to get something done in the salon if that's what we want to do. And you know, it's extremely common nowadays not to depilate in this area, and I just think we need to talk about it a bit more, and we need to do it properly so that we don't do ourselves damage. Can we have the next slide, please? And again, just looking at what different vulvas look like from the front. I mean, obviously on the left, we've got an area where we have removed all the hair. We can see the labia minora. This is normal. I will come back to that. Then different just distributions of hair, which are all normal. And it just depends on how people feel about their normal bodies. But I think they need to know what a normal body looks like. Next slide, please. So yeah, so this is labiaplasty. Labiaplasty means removing or reducing your labia minora, which were the little lips we saw just around the outside of the vagina. This is, unfortunately, has become probably the first or the second most popular cosmetic surgery in the UK in the last 5 years. And a huge number of young girls are having labiaplasty. And the reason for this is that they are accessing what a vulva should look like on a porn website or on whatever kind of a website, and saying, I don't look like that, and want to conform, which is what, you know, adolescents do want to do. And I have a real problem with this because young girls have not finished developing. They are growing, their breasts are developing, their labia are developing, and really and truly nothing in terms of plastic surgery should be done on these young women until at least they're in their early 20s. If at that stage something needs to be done, or the person perceives that something needs to be done, I would be recommending a plastic surgeon or somebody who has specific training in the area. Gynecologists are not trained in this particular type of surgery. I feel that a lot of women, as they get older, as they leave adolescence and come into their 20s, become a lot more confident about their anatomy. And I believe that the requirement for surgery diminishes here. We'll have a next slide, please. Yeah, so this is a gynecologist, Dr. Naomi Crouch, who is involved with Britsbag. And basically, you know, they have Britsbag have come out extremely strongly against labiaplasty, which I would absolutely agree with. No medical requirement for labiaplasty. Obviously, there are some girls who have extreme distress, and we need to deal with these people very sensitively, but we need to ensure that young girls do not embark on surgery, which can actually go wrong, which can have complications, and which is actually irreversible. So once we do labiaplasty, it's actually you cannot undo it. So this is actually very important. Okay, the Labia Library is a really interesting website from Australia, and it's extremely well written. It's for the public. There are pictures there of real, there are actually photographs of labia and of vulvas, and it just shows a huge variety of labia and vulvas, and normalizes the great variation that there is in this area. I'm wondering if I'm nearly over time. Can we have the next slide, please? Yeah. So this, I'm going to very quickly mention this. There's an awful lot of advertising for female hygiene and female health, female genital health. And basically, you know, most of this stuff, all it's doing is advertising. It's costing you money. It's causing a problem with the environment. We don't need any of this stuff. What we need for our vulvas is to keep the area clean with water. If you think about your vulval skin as like the skin inside your mouth, inside your nose, inside your ears, you don't clean that out with Femfresh, Chem Fatale, which I really love, and we don't cover them over with Always Dailies. So we really do need to just treat that area as if it were like our ears, without the buds. Next slide, please. That's a similar thing there. There's all sorts of interesting things that people are getting up to, but if you look at it, all they're doing is making money. The vapor rub one really interests me. I don't really know what that's all about. Can we have the next slide, please? Last thing I'm just going to mention, discharge is normal a lot of the time. It's obviously not always normal, but again, I think education for young girls around when you have discharge, how it changes, is actually very important, and I believe it's not really discussed in schools either. So there's a lot of anxiety and a lot of upset about discharge, because it changes from when you're prepubescent to when you're post-pubertal. And obviously this is all, a lot of it is hormonally mediated, and is extremely normal. I'm sorry, I've gone over time, but I think that will do me. Thank you very much.
Geraldine, it's so fascinating. And I think like something I'm sorry I neglected to say in the intro is just I'm so impressed by you establishing the teenage pregnancy clinic in Rotunda that caters for teenagers, providing obstetricians, midwife, and really importantly, social work advice as well. Could you just tell us a little bit more about the clinic? And then I've got a few questions that have come in as well.
Sure. So the teen clinic, we look after teenage girls up to the age of about let me see. So it's about 19 now. When we started, it's interesting. When we started, we just looked after teenagers up till the age of about 17. But interestingly, the number of teenage pregnancies has decreased, which is really rather wonderful. And what we've done is we've included now the group between 17 and 19 of girls who we would consider to be very vulnerable, either from a social point of view or from a learning disability point of view or from a mental health, anxiety, mental health suicidal ideation point of view. So we see all of these girls. What I really like about it is I work with a midwife who carries a mobile phone for the service. Her name is Debbie. She's marvelous. Wow. So she gets mobile like texts or WhatsApps or whatever. Now, obviously, it's not a 24-hour service because that's not tenable in anybody's life. But they can contact her. They come to see us every time, and so that we build up a relationship with them. And really, it's really very wonderful to see them coming in initially being really kind of scared, to them kind of bouncing in towards the end of pregnancy, because they know that they're in a safe space. So that's actually really good. Yeah.
I think that is absolutely incredible. I think it's remarkable as well. A question came in about surgery, and I was thinking this as well. It came in just now from Lorraine. Are there restrictions around that? Are there laws? Are there ethics around that when we're talking about even across Ireland?
Not to the best of my knowledge, no. There are very few people doing it in Ireland, and to be honest, I haven't seen anybody doing it in adolescence in Ireland, which is great, but there is no law, no, to the best of my knowledge. Yeah.
That's really shocking. I wanted to ask you as well, because I suppose being Canadian, I talk to a lot of my friends here about sex education in schools versus here, and it's quite different actually. But where do you see the role? I mean, would you see it very much as a joint role between school education and home education, or how would you see the breakdown kind of that, or in an ideal world, I suppose?
Yeah, I know that your Canadian system is wonderful from what I've heard. Wonderful in comparison to our Irish system. I see it actually. There's no easy answer to all of this. I think it really does start at home. I think the conversation at home, the attitude at home from the mom and from the parents around sexuality, around our anatomy, around our bodies in general, is actually really, really important. And I think we speak about it, and we need to be careful how we speak about it. But even with our attitudes to our own bodies, our children are picking up these attitudes subconsciously, and it's really quite interesting, and we do need to be careful about the language around all of that. And then obviously we need to get into a school situation. Again, I'm not really sure what exactly is happening in Irish schools in terms of education at the moment, and that's where I want to kind of go. I want to see what's actually happening in schools, and where, if we can come into educating and getting involved in that, because I think that's huge. What I've seen, and I'll stop now, what I've seen over the last year and a half in terms of the pandemic is a huge increase in the demand for my service, and a huge amount of anxiety about all sorts of gynae issues. And I really think that a little bit of background, basic knowledge could help to alleviate a lot of that anxiety and fear.
Absolutely. And I just think language at home, as you say, we really need to be positive about it, and informative and gentle and warm around all of it as well. And speak to sons, speak to daughters, fathers, mothers, everybody. Can I just ask one more question, and then we'll go to our next speaker? Jean said, can you tell us about this mysterious hymen, please, Dr. Geraldine?
So the hymen, so the hymen is a little ring of tissue, actually, around the opening of the vagina. So, and like everything, when you're a little girl, your hymen is entirely different to when you're a post-pubertal girl or a woman. And in fact, when you've had a baby, your hymen is entirely different to before you've had a baby. So it's a little bit of tissue around the outside of the vagina. In a little child, it is very fine, it is very thin, it is exquisitely tender, it doesn't stretch. And this is because you don't have estrogen here. Once you become post-pubertal, it totally changes, like your vulva totally changes when you become post-pubertal. So it becomes stretchy, it becomes what we call fimbriated, which is like it has little fingers, so that it can accommodate having sex, it can accommodate having penetration, it can accommodate a tampon. The idea of having to have bleeding the first time you have sex is kind of outdated. Not everybody does. And a lot of girls, before they've ever had sex, will have used tampons anyway. So there's all of that kind of myth stuff that has really been debunked.
We've outgrown
that one.
Dr. Geraldine Connolly, thank you so much for that. Thank you to everybody who's sending in their questions and bias in women's health. Our next speaker is Dr. Nóirín Russell on CervicalCheck, and of course we know it is a screening, and Dr. Nóirín going to obviously go through what happens with the screening. She's also very impressive woman clinical director of CervicalCheck, a medical graduate of the University College of Cork, and she has a long list of achievements. Dr. Nóirín, how are you?
Thanks, Alison. Thank you for the intro, and I'm delighted to be here today just to speak on a topic that I'm really passionate about cervical cancer screening. There's been some changes to the programme over the last couple of years. I'm going to take you through those, and I'm just going to try to advance my slide there now, which didn't advance. Sorry. So yeah, I want to take you through a little bit about what screening is and also what screening isn't. The program has changed from being based on cytology or looking at cells to looking at for the HPV virus, and I want to talk to you about that. A little bit about anatomy, but I mean, I think after Geraldine's amazing talk, I don't need to do much about anatomy. A little bit about symptoms and why, if you have symptoms that really it's not a screening test you need, it's a diagnostic test. And then who needs more screening, and a little bit about just Irish population numbers and the role of screening in cancer care. So screening is like having a giant sieve, and you put the population through.
Nóirín, I'm so sorry. Can I just ask you to go on to present mode? I'm very sorry if you can do that. Is that okay?
So my apologies. I thought I was on present mode. 1 second there now. If I share again.
Is that okay?
Yeah, is the sound okay? Is
there
a slight delay?
Perfect.
No, okay. Is that okay there?
Perfect, yes.
Perfect, yeah. Great, super. I'm in present mode now.
You got it.
Excellent, okay. So screening is like taking a giant sieve, and you put your population through the giant sieve, and what you're trying to do is you're trying to sieve out the people in the population who are at higher risk, and you take those people and you offer them a diagnostic test. So that's essentially, very simply, what you're trying to do. We know that screening works, and it decreases the incidence of and the mortality from cervical cancer in the population by doing this, by taking these higher risk individuals out and doing a diagnostic test. But unfortunately, it will not detect all individuals at risk. So it's a kind of a blunt tool, but it does have a very important role. So what I'm going to do, there's something funny with my presenter there. Okay, so HPV screening. We know that for every 1,000 women who have a screening test, around 20 in that 1,000 will have cell changes. So the majority, absolutely fine, but we're trying to find those 20. The old smear test would pick up around 15 out of the 20, but actually testing with HPV will help us detect 18 out of 20. So it's a much better test. We've got much less false negatives. Now, it's still unfortunate, as with every screening test, we won't pick up everyone. There will still be 2 women with who we won't detect, but it's much better. The 18 out of 20 is a much better test than cytology, which only picked up 15 out of 20. If a woman tests positive for any of the 14 high-risk types of HPV, then she's referred onwards for a diagnostic test, which happens in colposcopy. And actually, if a woman has 2 HPV positive test results, she'll still be referred to colposcopy, even if no abnormal cells are seen. And that's the kind of I suppose the extra layer of support. And interestingly, I was looking through the stats. 1 in 8 women who are screened are HPV positive. So I think I think we need to talk about that more. I was just thinking about, I suppose, again, that the bias, talking about HPV, it's hard. It's because it's associated with having sex. It does carry a bit of stigma. So I think that figure needs to go out there. 12% of women test positive for HPV, 1 in 8, it's very normal. Reassuringly, if you have a negative HPV test, the chance of developing an abnormality in the next 3 to 5 years is really low. And even if you have a positive HPV test, yes, you have to go and follow on through and get further investigation, but it does not mean that cancer is present. So HPV, as I said, is very common, passed on by skin-to-skin genital contact. Most people will get HPV at some time in their lives, 90% plus. Most people clear the virus through their system in 12 to 18 months, very common in younger women, and usually it'll clear out of your system. However, if you don't clear the virus and you keep this persistent HPV infection, especially if over kind of 10 to 15 years, over a long period, what it does is it irritates the cells in the cervix, and it's that irritation that can lead to cervical cancer. Now, it's really important that even if you've had HPV vaccination, it's still important to attend for screening, because HPV vaccination doesn't completely eradicate your risk of cervical cancer. It makes a big difference. We've seen some brilliant stats during the last couple of weeks about how it reduces your risk, but you do still need to attend for screening. So here's my anatomy slide. I find it really interesting when women ask me, you know, during a colposcopy or during a screening test, can you see my ovaries, doc? So it's important to note at a screening test, or when as a doctor, I put a speculum into someone's vagina, I can only see the lower part of the cervix. Don't even see the full cervical canal, actually. And I can't see anything to do with the uterus or anything to do with the ovaries. It's really looking at the vagina and looking at the lower part of the cervix. So the cervix, the average cervical length is around 3 centimeters. We only probably see maybe the lower 1/3 at the time of this test. And that's why you'll hear us talking about in the program, you must always attend for your GP if you have symptoms, because at the screening test or at that exam, we've kind of looked at the lower 1/3. But if you get unusual symptoms, don't say, oh, to yourself, oh, well, I had a normal screening test. You must go and have that looked into. So that brings me on to symptoms. So if you've got irregular vaginal bleeding, that is bleeding between periods, spotting or unusual discharge for you, bleeding after sex, or bleeding after the menopause, these are not normal symptoms. And these symptoms should shout, oh, red light here, better go and see my GP. A lot of the times it's not cancer, but these are the things to look out for. No screening test is 100% accurate. So if you get these symptoms, you should attend your GP and chat with them. Another question we get asked a lot about is, you know, should you do more screening? How could we do more? There's a really important message in this slide. It's a bit busy, but the bottom line is women over 50 are less likely to attend for screening. And we know that it actually, the drop off, our young women, nearly 90% of them attend for screening, 90% of the eligible population. But when you come up to the 50-year-olds, it goes down to 70, 72, 73%. And I think that ties with a lot of Loretta's work on menopause. It's kind of like women become, you know, postmenopausal, and they think that this screening thing doesn't belong for them anymore. And I think it's really important we get that message out. You know, from up to the age of 65, we've now extended to at 65. So women are still encouraged to attend for screening between 50 and 65 because it reduces their risk of cervical cancer. This is another interesting one. The population program, we're aiming to get 80% of eligible women. OK, but we know that in 6 counties, less than 75% of eligible women attend for screening. We don't know why. So if there's anybody online from Dublin, Kilkenny, Monaghan, Roscommon, Laois, or Clare, I'd love a perspective there, because there's very obvious. It's less than 75% of women attending for screening. So I think that's something we're, as a program, interested in and working on. We've done some work during the year about cervical screening in migrant communities and reaching out to people where English is not their first language. We now have the CervicalCheck video about screening, about HPV screening, available in 21 languages. I want to shout out to Translate Ireland, fantastic organisation who got this up and running for us. And it's been brilliant. A lot of GPs have texted me and said, listen, I had a woman in, she doesn't speak English, but I showed her the video, and how powerful it is to hear in your own language, this is what screening is about and this is why I should attend. Another question we get asked a lot about is, why are you not screening under 25s, and I'm 20 and I'm sexually active and I'd like to be screened? But it's important to note, screening is actually it's a balancing act. It's a balancing act between benefits and harm. And the potential to do harm for women under 25 outweighs your potential to do good. So HPV infection is incredibly common in this age group. But as I said, most people who get HPV will clear it out of their system. When the HPV is present, abnormal cells are really common in this age group, but the vast majority go back to normal without any intervention. And in fact, identifying and treating abnormal cells in this age group has the potential to cause cervical damage, which could lead to late miscarriage and preterm birth in the future. So we have to be careful. We don't want to have an intervention, or we don't want a test that leads to harm, because that's just not in the, I suppose, in anyone's best interest. So actually, what in this age group, it's false positives are the risk, not false negatives, but a screening test that's positive and actually turns out to be nothing, but the risk of an intervention if you follow on and through in that. Now, I will say, again, if a person under 25 develops symptoms, they should attend for screening. I had the box of symptoms up. They're important no matter what age you are. So a little, I'm going to just finish up just in a few numbers. I know it's Science Week, and I do love a few numbers. I'll try not to bore you to death. But a year in the program, what's the Irish population numbers? So every year, around 270,000 women attend for screening. 90% who attend for screening get a normal result and they forget about it until they get the next letter. And around 15,000 women are referred onwards for a colposcopy. That's a diagnostic test for where we as doctors can look at your cervix with a microscopic kind of focus and really look and see if there are any abnormal cells there. In colposcopy, approximately 6,500 women every year are treated for abnormal cells. The vast majority of them do not go on to get cervical cancer because that treatment removes the abnormal cells, and again they have their follow-up tests and can forget about it and never go on to get cancer. Every year, unfortunately, approximately 150 women are diagnosed with cervical cancer in colposcopy settings. So because a screening test has happened, they go on to have colposcopy and get diagnosed. And this is the important one. Another 100 to 150 will be diagnosed in gynae clinics when they develop symptoms. And you'll often hear us as program staff, we're always, I suppose, cognizant of where we fit in the whole overall ecosystem of health. So yes, screening is important, but women with symptoms are important as well. And they need to be able to get access quickly to a gynecology clinic and get checked out. And they need access to their diagnostic tests. And that's something that we're really keen to advocate for as well. So the final slide it's just about the balance. So screening is important in cancer care, but it's not the only show in town. So every year, 24,000 Irish people are diagnosed with cancer. Approximately 1,500 are diagnosed via screening, and of that 150 are cervical. But 22,500 people are diagnosed with cervical cancer when they attend their doctor with symptoms. So that's why we as a population, we need to advocate for access to GPs. When people have symptoms, they need to be able to get in to see their GP. We need enough GPs. We need enough specialists and consultants when these symptoms need to be referred on. And people they have a right to the access to diagnostic tests, CT, MRI, ultrasound, etc. So whereas I'm obviously a huge advocate for screening, I'm also very cognizant of advocating for access to diagnostics as well. So takeaway messages: screening with HPV is better than screening with smear tests. Screening reduces your risk of cervical cancer but won't detect all cancers. Women and people with a cervix must still attend for screening even if vaccinated for HPV. It's important to know the symptoms and attend your GP even if you had a recent negative screening test. Women and people with a cervix over 50 still need to attend for cervical screening. We need to address this geographical variation. It concerns me. And as I said, 24,000 people per annum diagnosed with cancer. 22.5 of those are diagnosed in symptomatic services, 1,500 in screening. Thank you very much.
Nóirín, that's absolutely fascinating, and the numbers are fascinating as well. I think we all like numbers, especially on Science Week. We've got some questions that have come in, and I suppose one of them is all about the HPV vaccination uptake and, a knowledge around that, awareness around that. And I know I actually would be keen to know that myself, as all of this is quite interesting to me because I do have a child that's just beginning puberty. So how can we improve this? And could you just talk a little bit more about the vaccine if you're comfortable doing that?
Sure. So the vaccination program runs separately to CervicalCheck. It runs from the National Immunisation Office. But I had an update on this topic during the week, and the figures are looking actually quite good. So we have 73% uptake in our boys and girls. So I don't have a gender specific one, but I know 73% of eligible teens. And of course, it's brilliant. We're now vaccinating boys as well, which I think is fantastic.
Yeah.
And so that's good. It could be better, but compared to where we were, I think I'd have to, if I'm going to talk about vaccination, I'm going to have to mention Laura Brennan and her incredible advocacy work, because I think that was a real turning point. We had seen vaccination rates plummet. They were down at 40%. It was terrifying. And I think really her advocacy work turned that around. We're back at 73%. Of course, we could be better. I'd love to see it higher. But I think in the years, in the pandemic, in the time that's been, I think 73% is good, but more needs work.
Okay. Also, I know you touched on this, and I think it's so important to reiterate this as well, is that even if you do get a clean cervical check and the letter comes back saying nothing's been detected, if you do have symptoms, go to your GP. But what types of cancers are there that screening will never be able to detect? And obviously, you know, your advice, I imagine, again, is for women to make sure they're definitely going to their GP if anything changes.
Yeah, that's a super question, Alison. So we know that screening is really, really good at detecting squamous cancer. So there's two main types of cells on the cervix. There are the squamous ones, which are like your skin, they're like the skin on your hand. And then there's the glandular cells, which are more like the skin, the cells on the inside of your cheek. So they're a little bit more moist and a little bit more plump. We know that screening is excellent at detecting squamous cell cancers, and they're the ones that are most commonly associated with HPV. Glandular cancers are less well detected, less able. Now we do pick up some, but it's just tougher. Screening is not designed to pick up glandular cancers. There are other rarer types, things like small cell carcinomas of the cervix, but the kind of stats wise, it's around 92% of cancers, of cervical cancers, are HPV associated. So we know that none of the screening tests, unfortunately, are particularly good at picking up the others, and that's why you'll always hear that balancing message. So it's brilliant. Getting a negative screening test is really good. It's really reassuring, but don't ever let it prevent you from investigating symptoms. So if you get symptoms 6 months after irregular bleeding or postcoital bleeding, 6 months after you've had a negative screening test, don't think I'm probably fine. Think I should go get that checked out.
Absolutely, absolutely. And Nóirín, I suppose one big question that, you know, a lot of people might have as well is just, you know, how we want to have trust in the program, and, you know, obviously that's the message to get there. What would you say to that? Like, just people go, listen, you know, don't be cynical, trust in the program. As you said at the very beginning, lots of changes have been made as well.
Yeah, I think it's been a really, really tough time in Ireland for cervical screening. There's been a lot of negativity, there's been a lot of fear, there's been a lot of mistrust, and I guess you don't get trust back just by saying, hey, trust me, you don't worry, you can trust me. And I think that's what trust is earned, and I think that's what the messages I suppose I'd like to share today is to say that improvements have been made to the program, improvements have been made in governance. We have a really, really strong governance line now. We've put in a lot of extra supports there. And we're working very hard on the communication piece, because I think there was a failing on our part to explain the limitations. I think prior to 2018, I think the screening program was really good at talking about the positives and what we can do and how brilliant screening is and how much of a difference it can make. But perhaps we weren't as good at talking about the limitations and saying what screening can't do. And I think it's the balance, and I think that's what builds trust. We found time and time again with our website, with resources, with the questions that come into the program, people want info, like information. Look, I'm talking to the conversion. We're at Science Week, but it's information, and the more information you put out there, the more transparent you are, the more open you are, the more you talk about what can and cannot happen. I think people really appreciate that.
I think it's fascinating, and definitely the message is to get tested. And I mean, I don't want to go on about the Canadian thing, but when I first moved here, I had a lot of friends that were in their mid to late 20s, we'll say late 20s, early 30s, that hadn't had it done yet. And I was like, this is a great dinner party talk. And they're like, oh, invite Alison to the dinner party. This is going to be great. And I'm like, have you guys had your smear test done? And they're like, no. And like, we'd book it then and there. So I think it's fascinating. And thank you so much for your time this morning. And thank you to everybody who's got questions into us as well. Our next speaker is joining us now. She's got her slides ready to go. It is Loretta Dignam from the Menopause Hub. And this is something that, if you heard our chat with Dr. Jen Gunter yesterday, it is something that, you know, we need to talk about more as a society. We need to be open more about it, and I suppose more leadership in that role from the medical profession, and maybe, you know, people in the spotlight who are willing to talk about it now, because it's a stage of life. So we just need Loretta to turn her camera on to join us and to go into live mode and presenter mode. And I think it's really, really important, and it's obviously a stage of life that many of us go through, and we want to be able to speak about it in a very, very positive light. So Loretta, you're welcome.
Thank you for having me today, and thank you so much for hosting this event. I think it's absolutely fantastic. I'm all about the data. Now, if I pull up my slides, will you be able to see them?
Yep, we can see them there. Yeah.
Brilliant, brilliant. Okay, so my name is Loretta Dignam. I'm the founder and CEO of the Menopause Hub. I set up the Menopause Hub, which was Ireland's first and only dedicated menopause clinic in December 2018. And I set it up born out of my own experience of going through menopause and finding that the services that were available were very limited or poor. And when I went on to Dr. Google, I got confused and found it very difficult to navigate the conflicting information. So I set up the clinic, which is basically a clinic, a multidisciplinary clinic. We have medical doctors, gynecologists and GPs with and all of special interest and training in menopause. We have a psychologist, we have a dietitian and nutritionist. We have a women's health physio and we have an acupuncturist. So we try to offer an holistic solution. So so that's our clinic. I also advocate for women for menopause, and I also have set up programs for organisations who want to support women going through menopause. So my first slide here is, if anyone hasn't read this book, I wholeheartedly recommend it. I read it when it came out and I found it life-changing. So Invisible Women, Exposing Data Bias in a World Designed for Men by Caroline Criado Perez. I don't know if that's how you pronounce it. Anyway, she said, we need a revolution in research and the practice of medicine, and we need it yesterday. We need to train doctors to listen to women and to recognise that their inability to diagnose a woman may not be because she is lying or being hysterical. The problem may be the gender data gaps in their knowledge, said as little as last year. And this is no more the case than in the area of menopause, which for many years we have hidden under the carpet. It's been taboo. So why is menopause at work relevant? Why is menopause relevant? But by 2030, there will be 1.1 billion menopausal women on the planet, 12.5% of the global population, 47 million menopausal women will come into this cohort every year. In the UK, it's 14 million, with 4.4 million in the workplace, and it's the fastest growing demographic. In Ireland, it's 570,000 women, of which 350,000 are in paid employment, and it's also one of the fastest growing demographics. So menopause is a very multifaceted issue, and I'll explain why in a minute. It's a societal issue, it's a healthcare issue, it's a workplace issue, and it's an economic issue. And I'll explain as I go. The problem is that it's been taboo. And when we asked women in Ireland how taboo they felt it was, on a scale of 1 to 10, where 10 was most taboo, they gave it a score of 8 out of 10. So really, there's a revolution going on in menopause right now. And what we're trying to do is to smash this taboo. So here's some data. So 50% of the population will go through menopause. So every woman will go through menopause. About 85% of women will experience symptoms. So it's a staggering amount of the population that will go through this. And the other 50% may be impacted. So family, partners, husbands, and so on. And I conducted research because there was no data available in Ireland in 2020 among 1,250 women who are menopausal in Ireland. And 80% said that they were unprepared for menopause. So they weren't prepared, blindsided. I had my last period the month before I turned 50. I then started hot flushes, and they were the only two things I knew. So I was blindsided. I thought it happened to somebody much older than I was, maybe late 50s, maybe early 60s. 66% know little or nothing about menopause. Hot flushes and no periods is fairly little or nothing. 79% rated the information and services for menopause as poor or very poor. So 90% of them said they had symptoms. 60% described them as moderate, and I would describe my menopause as moderate. And yet I felt compelled to open a clinic to help other women. And 30% described them as severe. And that was from research conducted just this October amongst 1,150 women. So you can see this is why it's a societal issue. In terms of symptoms, and this is a symptom checker, very busy chart, but sorry about that, but it was what we give to women who come to our clinic as patients, and we share it widely with women. And what it does is it breaks down, there's over 40 symptoms of menopause, and most women only know about hot flushes and maybe no periods. But there's a whole load around what we call the mental, emotional symptoms, so memory loss, mood swings, depression, anxiety. I'm staggered by the amount of anxiety that women experience in perimenopause, which is the lead up to menopause. The average age of menopause is 51, the average age of perimenopause is 45, And the length of time, the average length of time that it lasts between peri and post-menopause is 7.4 years. So it lasts a long time, affects a lot of women, and there are a lot of symptoms. Women are anxious, overwhelmed, they're weeping, they're crying, they're grumpy, irritable, they bursts of anger, panic attacks, flat mood, loss of confidence. Women go to the GPs, and they say maybe amazing GPs out there, they don't come, the women who go there don't come to our clinic. But the women do give us the feedback and say, as soon as they mention mood, out comes the antidepressants. So there's also physical symptoms, and they can be also including stiffness, aches and pains, which I have pains in my ankles, heart palpitations, dry eye. I ended up in the eye near 3 times with dry eye in the A&E department. I also had headaches, and I developed migraine with aura and was sent for brain scans. They came back thankfully normal, but nobody mentioned menopause. I put on about 10 pounds. I had digestive problems, acid reflux, irregular periods, muscle tension, allergies. I mean, the list goes on. Insomnia affects so many women. And then there's a whole load of what we call genitourinary symptoms, which we talk even less about, which is loss of libido, which can impact relationships, painful sex, vaginal dryness, something that only gets progressively worse as women age, discharge, bladder issues, so UTIs, urinary tract infections. I was plagued with them in my 40s, spent most of my time on antibiotics. And incontinence, which can be, laughing, coughing, sneezing, leakage, or it can be much more severe than that. And so when you see those ads on TV that say, oh, wear a pad, a panty liner, a little leak is normal, it's not normal. You should check that out. But what nobody talks about is also the long-term health impact of the lack of estrogen. So once a woman goes into perimenopause, the estrogen level starts to decline, and it fairly much falls off a cliff. So living in this estrogen deficient state, which can be up to 1/3 to 1/2 of our lives, puts women at greater risk of heart disease. Heart disease is the #1 killer of women in Ireland and globally. 1 in 2 women will die of heart disease. It puts us at risk of osteoporosis. So we lose 2% of our bone density a year post-menopausal. And what that means is that we're at greater risk of osteoporosis, and 1 in 2 women will have an osteoporotic fracture in their lifetime, which can render them dependent because they lose their independence and mobility. The other area is the whole area of Alzheimer's and cognitive function. And we know that women are 3 times more likely than men to get Alzheimer's. So when I say it's a health issue, I went throughout my 40s to numerous appointments with various specialists for tests that actually, if somebody was able to join the dots for me, or I was able to join the dots, would have been maybe unnecessary. So that's a cost and time, money and resources from the health services. And then we get into the longer term and we have these issues of heart, bone and cognitive disease, basically. So we're at risk of these things, and it obviously is a cost to the state. So it's also an economic issue. I've also done some work around, some research around menopause in the workplace, and I did a survey this year in September and October in over 1,100 women. And what they told us was, and part of this only data existed in the UK, and I was fed up quoting UK data, but just over 50% of women said their performance was affected a little at work. I remember when I was in work, I got 20 to 30 hot flushes a day. That certainly impacted my performance. And just over 30% said that their performance was affected a lot at work. 39% of women have missed time off work due to their symptoms, so they've taken time out. 22% have missed 3 or more days due to their symptoms. And 86% didn't feel confident telling their employer the real reason for time off. Now, not every employer needs to know the reason, but even if the women wanted to tell them, they'd be embarrassed. So you can see this is an economic issue, it's a performance issue, it's a productivity issue. So organisations need to wake up and look at this and look at how they can support women and retain talent. 43% considered giving up work. Now, this research was done post-COVID, so I know there's been a lot of thinking among people about what they should do because of COVID, and 12% actually gave up work. This is higher than the UK, which is at 10%. 60% lacked confidence discussing menopause with their colleagues, 70% with their line manager. And a staggering 90% plus wanted training for managers and HR around menopause so that they could have a conversation and feel supported in the workplace. and over 90%, in fact, over 95% wanted a menopause in the workplace policy. What women need now is what I'm calling the 3 A's. Awareness. There's no awareness campaign for menopause on this island. There's campaigns for all sorts of obscure diseases, and there's no insult to anybody suffering from those. But given that 50% of the population would be affected, we need an awareness campaign, and I've been advocating for this, whether it's radio, whether it's leaflets in GP surgeries, whether it's online, etc., etc. The second A they need is accessibility, and I know the previous speaker, Nóirín, spoke about that, but access to GPs who know how to deal with menopause and to talk about it, or at least a GP per surgery. There's also a role for nursing in this, for nurses to help out with accessibility, because women are going to GPs and to their surgeries and being given misinformation or the wrong information. But as I said, there's some great GPs out there, but not all, and it's very hit and miss as to the level of care women will get. And the third A is the area of affordability. So our clinic is a private clinic, and we treat women, which is fantastic. We give a small discount to women who are on the medical card, but medical card patients can't avail of this kind of a service. And in the UK, there's been a bill passed just recently, a couple of weeks ago, where they're cutting the cost of HRT, repeatable HRT prescriptions. My HRT, I'm on estrogen, progesterone and testosterone, which I didn't know women could take, costs me around €75 a month. That's a significant cost. So I've been advocating with the government to actually introduce reduced costs. My last slide is that from a business perspective, there is a business case for change. We have a duty of care to our employees, so safety and well-being is important. Performance, women say their performance may be affected and they may need some support. It's a talent retention issue, and we're trying to keep more women in the workplace, and in their late 40s and early 50s. This is when they're at the peak of their career. And it costs more money to attract new talent and replace talent if they've left. From a legislative perspective, there's a risk as well, because there's been a number of employment tribunals in the UK, an increasing number, where they've ruled in favour of the menopausal woman on the grounds of sex discrimination, age discrimination, and in 1 or 2 cases on the grounds of disability. Now, we don't want menopause to be considered a disability, but the legislation in Ireland and the definition of disability is much wider than it is in the UK. And let's face it, we need to operate by the carrot approach, which means that there's a great business case for addressing menopause in the workplace, rather than the stick approach, which is fear of legislation. So that's all I want to say today. If you need to contact us about menopause in the workplace or whatever, you can get us on our website, themenopausehub.ie. And really, thank you for your time today, for inviting me to present and to share information on this much neglected topic of women's health. Thank you so much.
Loretta, that's absolutely brilliant. And I mean, I would be a massive, massive advocate of this becoming a much more open and supported topic in society as a whole, and from the medical profession to talking to our friends and everything, because I think it's very outdated. We all have memories of our mothers just with the only option was to just stick up, like put up with it and stuff. Yeah, and it's just not that way. And even perimenopausal is a phase of life. It's a really even new concept in many ways to a lot of us. And it's important that we look out for the symptoms and we don't dismiss them, and that we know that there are ways of, making this a nicer transition in our lives and a healthier transition as well. We messaged in for you. Loretta's experience sounds exactly like my own mum, who'd been going through menopause for over 15 years. She has suffered greatly at times. Much understanding needs to be surrounded around the whole area. So thank you so much, Loretta. And another one came in saying, how can women mobilize themselves to support each other in workplaces and influence work policy? Because work policy and our lives as working women, there's many years where the two cross over, and there needs to be vast improvement.
Yeah, actually, since that Joe Duffy show during the summer, which that really lifted the lid on menopause in Ireland. And what we discovered, well, our phones were overwhelmed with appointments and booking and whatever. But also we got an influx from employers saying, this has come up in our workplace. We'd really like to know how to address this. Can you give some advice? Can you help us? And so on, which is brilliant. But how women can do it is, and I'm a great believer in safety and power in numbers. So women can get together and set up their own social groups within work. They can then maybe go to the HR department and say, look, there's a number of us experiencing this. We would like this to be addressed within the organisation. And there's lots of supports available, from very simple things that can be reasonable adjustments that a woman can get, which, you know, could be adjusting the temperature at her desk or sit beside a window. And as women go back into the workplace from home, they may need more help in adjusting those. So yeah, there's women can help other women. Women can speak to their employers, and the employers can seek help and guidance from organisations like ourselves. So I do think it's emboldened on women to start educating themselves. That's really, really important around what the symptoms are. There's a huge level of denial as well, because nobody really wants to be a menopausal woman, because it kind of means you're old and maybe, you know, crazy lady and a bit past it. So we need to break down the stigma around this as well.
Absolutely. And I think, Loretta, actually, the more and more women that are in the public eye, and this is across the board, this is, you know, from the very, very famous to locally famous, the more and more that are very vocal and open about it and progressive about it and positive about it, it will only improve everybody's situation. And I can say with safety that even myself, I have a twin sister, and even the way that what she's living with me for the moment now, and even the way she and I were talking about it, I was like, no, she's got a very old school kind of way, and like, so we need to kind of change all of our mentality around it all. I was just going to ask you one other question, then I'll read the other ones that have come in. Treatments for menopause, like, is it a situation whereby it's individual, each individual will require something else, there's no blanket treatment, or what are your thoughts and awareness on that, Loretta?
Well, in our clinic, for example, so no two women are the same. So no two women's menopause is going to be the same. And there's been a huge fear built up around HRT, hormone replacement therapy. And there's been a lot of work done to unpick that research that was done by the Women's Health Initiative that caused all the issues back in 2002. But it's done untold damage, and the fear far outweighs the benefits that can happen, that can be derived from HRT. So that's one thing that also needs to be destigmatized, I think. But, you know, each woman comes to our clinic and has a different set of symptoms, and therefore their treatment can be individualized. And if they go on HRT, can be titrated up or down to suit them, their needs, their symptoms. If they decide on non-HRT routes, that also can be done on an individualized basis, based on their symptoms.
Thank you, Loretta. It's fascinating. It really, really is. And I hope that, you know, even this conversation alone will generate other conversations, and it will move on to, you know, become less stigmatized. Absolutely, which is what we really, really need. So thank you, Loretta.
Thank you.
Thank you to everybody. There's loads of questions coming in. #BiasWomen'sHealth, and on Instagram and Twitter @BiasWomen'sHealth. And a lot of people asking us actually about whether it's being recorded. It is being recorded. It will go up on the website afterwards. Going back to something, I think it was Nóirín said this, you were talking about translating messages about the cervical check into different languages. As always, we know it's a multicultural country we live in now, and it's translateIreland.ie, set up by Graham Clifford and Dr. Catherine Clifford. So whoever was asking that, hopefully that answers that as well. You can always get your questions into the box that's up on the top of your screen. Now, Rhona Gaynor, Women's Health Task Force, a lot has happened in the last year. This is a massively, massively important project, and she joins us now to give us an update on the Women's Health Task Force, as well as what's next. And Rhona, how are you?
I'm great, thank you, Alison. Delighted to be here this morning, and I know you had the benefit of Rachel, our chief nurse, last year speaking about our progress at that point. So delighted to be here and talking about what we've been doing since then. You'll know, of course, and we all know, that there's a long legacy of work on women's health in the Department of Health, but our business is continuous improvement, and that's the work of the task force, and that's what we're trying to drive forward. I'm the women's health lead in the department, and a lot of my role is about trying to bring together that massive work that's happening across the health sector, and then also, you know, push it forward and drive it forward as well. So Holly, you can move on, thanks. So, I mean, one of the most significant statements we can make about women's health in the state today is that this is a government priority. We know clearly in Ireland and internationally that gender is a determinant of health. So your gender will influence your health outcomes, and that's as true in Ireland as it is internationally. Women have very specific physical, mental, social health needs, and you've heard just examples this morning from different corners of health and the health experience that women can have. We also know, though, that women's health outcomes and their experiences are so affected by the role that they play in society, the role that they play in their family, with women often taking on that additional caring responsibility for people in their network, in their world, and often accessing and coming into our health services as advocates, not only for themselves, but advocates for others. And there's a burden associated with that we need to start to recognise as well. Women's health, as I said, is a priority for government. It's included in the programme for government. It's a very clear statement of intent. Minister Donnelly, you'll have heard him this year making very clear commitments and ambitions around women's health and progressing women's health. That was very strongly supported in Budget 2022 in the month of October. So you'll have seen 31 million in additional funding for women's health, and that's for new developments in women's health where we're trying to push and drive forward service improvements. So that is a big achievement and a big milestone in our programme of work. So we talk a lot in the Women's Health Taskforce about outcomes and experiences, and we're very keen and focused on keeping that dual track. So we want to use this platform, use this partnership that we have built around the Women's Health Taskforce as an opportunity. We want to tackle gender inequality where it exists and try and reduce it. We want to meet women's expectations, and we've spent so much time that I'll speak about trying to listen and understand and connect with women, so that we really understand what that need is, what that expectation is. We know that within and across government we have the National Strategy for Women and Girls, a big overarching piece of cross-government work that's looking to reduce those levels of equality in every sphere, and health connects and plugs in under that strategy. We want to use it, and a lot of what the task force is about is also an opportunity for the Department of Health to lead and to show our capacity to collaborate, to partner, to look inwards and outwards to try and drive the type of change that we're looking to see across the country on women's health. And that's a big part and a big inspiration for how we do our work and the way that we're approaching it. And of course, and connected to some of what Nóirín spoke about, you know, this work began in 2019, and it was one of the recommendations of Gabriel Scally that the department really look at how it's working itself and how it can work differently to provide more consistent, more expert and more committed attention to women's health. And so that's been a big influence on how we're approaching the programme as well. So what have we been working on? 2020 and 21, we had a very defined set list of 5 key priorities. And top of that list and chief among them was listening to women about health and healthcare and what those healthcare needs were. And I'll take you through in a few slides some of the really critical insights that have emerged from that work. Linking to Loretta's work, we've had menopause as a very strong priority since day one, so supporting women before and after and looking at that whole holistic health approach at that point and phase in life. Improving women's gynecological health has been an area of focus for us, a priority for us, and that's inclusive of pelvic health, gynecology, looking at issues like endometriosis, so really trying to dig into that topic and try and drive key elements ahead. Another element has been around increasing support for older women to become and stay physically active. And I suppose, you know, what we're trying to achieve through the task force is keeping that rounded sense of health. This isn't just about reproductive health. This isn't just about, you know, factors pertaining to sexual health. This is women's activity, women's wellness, mental health, and that full spectrum of living a full and healthy life are the areas that we want to target and the areas we want to change. And I suppose connected to that, planning and trying to look at our mental health support, look at our mental health support network for women and girls and assess, you know, is that delivering, is that looking at services through the lens of gender and delivering for women has been our number 5. So we've been very focused on those areas, and you can see there we have a link to more detail, and you can see exactly, you know, how we've been progressing and what we've been looking at under each of those territories if you follow that link. Who have we been working with is also, you know, something that we're kind of really proud of and really excited to talk about. So the Taskforce is a partnership model. It is led by a huge number of staff from within the department, and that's very intentional and deliberate to show and embrace our commitment to women's health across the department. But we also have a set of health system partners that come from other agencies like the ICGP, the HSE, the Institute for Public Health. We also work with advocates and wider stakeholders, and Alana is going to follow me shortly from the National Women's Council, who've been, you know, key partners of ours since the beginning, along with the European Institute for Women's Health. But right at the centre of that work, which is expansive and inclusive, has been the voice of women, and that's, I suppose, the most, you know, distinct characteristic of this piece of policy work at this piece in time is the centrality of women's voices and trying to bring women's voices into the process really early, you know, as continually as we can, so that we really understand what that ask is, what that experience is, what that expectation is, and so that policy can be learning and designing and coding that in as we go. So very much turning the consultation model on its head, where, you know, we work internally to get the perfect answer and then check it externally. So really trying to do an outside-in process and put women at the heart. So what have we been learning, you know, this past year? So we're seeing from the evidence, from the deliberations that we have through the task force, from the experiences that women are sharing with us, we're starting to see a number of common themes. And again, all of that material is published, you know, very transparently on the Women's Health Task Force web pages connected to the Department of Health. So it really encourage anyone with special interest to follow and chase down some of those elements within that page as well. But really, we're hearing a very strong request, a very strong ask to listen. So women want that from the health sector as a whole, including health managers and the civil service side of that. They really also want it from their health professionals. So we're seeing that really clear ask for kind of conversation and partnership, you know, partnership health and partnership medicine coming through. We're also hearing through all of that evidence, and you can see it again as a really interesting theme emerging this morning around information, reliable, trusted information. And also from our different age groups, we get a different sense of, you know, what that might mean for different groups of women and different age cohorts of women. And so we need to think a little bit creatively about, you know, what is that and how do we try and respond to that appetite for better trusted sources of information. We hear a lot about services and access to services, and I can, you know, echo and see that echoed in Loretta's work, and that's going to come through as an important pillar for us now in 2022. Improvements around care and a focus on priority groups, and I'm so pleased that Alana is going to speak just following this input, because Women's Council have really supported the task force to look and explore, you know, with priority groups of women who have, you know, particular experiences of healthcare, so that we really understand and challenge ourselves to make sure that we understand that diversity of experience for women. And it's not just one thing, and we're not just a, you know, one group. There's so much diversity there that we need to make sure we understand as well. So this year led to our radical listening exercise, and Rachel, I think last year, was speaking to you about our plans for how it would unfold. So we led a radical listening exercise in women's health. It was nationwide, and the purpose was to try and give women an opportunity to share that experience piece. So how they had found access to services, how they had found services when they were in them. So we had almost 270 women contribute, largely through workshop sessions, which were, very honest and very candid sessions about their experiences of health. And again, that report was published in full. You can find it on our website, and I would really encourage, if you have, in the course of Science Week or in the course of a coffee morning next week, 10 or 20 minutes to look at that. That feedback is really important, I think, for all of us to acknowledge, what women are telling us is their experience at this moment in time. So we heard really interesting messages about the best parts of healthcare, and we're really keen to understand those, to keep those bits, to grow those bits, and to make sure that those best elements can be coded into so much of what we do for women in the country. So we heard a huge amount about listening and empathy. We heard about services that are proactive, that are tailored, that are female-centric. And Nóirín, I know, will have seen the report and will be pleased that screening is one of the things that's really referenced there for women. They love that the letter comes through the door. They welcome that proactivity, that sense of being asked and invited to take a step to mind their own health and take it forward. We heard so much about great and positive outcomes from women, and that's really reassuring, and that's really important, and we need to keep looking at that and make sure that it's consistent. But again, a strong message coming through about people feeling that their health had improved through their contact with the health service. And then we heard a lot as well about trust, and how important a lot that was referenced here was the relationship with GPs, how important that is to women, that having an open, a trusted relationship where they can begin a dialogue. And again, when we talk to clinicians, and we did a lot of roundtables recently, we did a roundtable with GPs, they'll often tell us too, the most important bit comes in minute 9 of a minute 10, discussion, where once that trust has been built, there's an important piece of information shared. So women are echoing that as well. So again, some really important, really positive elements of how we're approaching the health and the healthcare of women in Ireland at the moment, and of course really big areas where women are asking us to make improvements and to change. So as much as we need to bank and keep and preserve the positives, these are the target areas for us now for 2022 as well. So, women would have spoken about limited information. Again, that topic and that theme of information, wanting a fuller discussion, and feeling pushed for time, or feeling, pressurized and not maybe able to touch on taboo subjects or issues that are harder to broach. We heard from women about not being treated as an individual in the system. And there's some really important messages in our report around that, and I'd encourage you again to kind of look at the detail of that. And it's something that socially and in society we need to consider, we need to reflect on, but particularly within the healthcare system, and think about our approaches, our methodology across health. Is there something different we can do whereby women are seen and heard and are within a service that's treating them as individuals and with the respect and the dignity that comes with that. We heard a lot from women, and again, this differed across age groups, and our research looks at different ages, and it's very interesting from that perspective about carrying that burden, that caring burden. And we saw that particularly as our age groups progressed. So in our workshops with women over 50, often just demonstrating the pressure of minding your own health, minding the health of family members, and that pressure that can exist and can be carried. And we have the data that shows that women are often carrying that higher burden of caring, and a sense that our mental health supports and our social supports need to really make sure that they're wrapping around women at that time as well. And we did hear through these workshops and the perspectives that women spoke about the system being out of touch. And that's something that's really interesting and really important for us to look at and talk about a bit more. And a lot of what women were asking for was, more female representation, more female leaders in the health sector, more access to female clinicians. And, you know, I think you can hear as well in some of what Geraldine was talking about, you know, there's so much growth for us to, you know, understand and embrace issues that, you know, previously maybe, you know, we wouldn't have been so good about being forthright around. So that out of touch piece coming through quite strongly for women as well. So our big focus, and you would have seen it in my earlier slides, listening to women, getting that view and sitting and making sure we understood it was priority number one for this year. And we're really proud of that research, and it's an important underpinning to what comes next. We also had in 2021 for the first time the Women's Health Fund. So this is a fund that hadn't existed before this year. It was awarded in budget 21 at the value of 5 million, and our job across the task force and within the department has been to try and link that to our priorities and make sure that we can bring progress through those areas that we're trying to tackle. And you can see here that the investment connected to that fund has led to and is leading to, it's an emerging process, and we're going to keep minding these projects, but is leading to lots and lots of change that lots and lots of women will benefit from. So the investment supported see and treat gynecology clinics, where, you know, multi-professionals are wrapping around a woman to try and support. It supported the endometriosis service in Tala, a really important service that, again, when we started this process, women were really, you know, telling us about that need. It connected in and supported that specialist centre for child and adolescent gynecology, and you can hear, you know, from Geraldine this morning some of what's really important about that being there as a service for our younger women. It supported the introduction of the first specialist menopausal clinic, not the end of our work, but the beginning of our work in trying to transform that kind of sector and network of care for women experiencing the menopause, of course, a lot of which happens and needs to happen at primary care level. And you can see there just a list that's emerging and that's growing around pelvic health, mental health, contraception, and so that's our legacy emerging from 2020-21. Our job now is to keep that progress and grow that progress, and also to turn our attention to issues that have arisen this year that we need to focus on in 2022. I think I have another slide. Thanks, Holly. So what's next? So at the moment, we're very focused on 2022. And we've agreed that we will publish a Women's Health Action Plan focused on 2022. There are going to be lots of inputs. As you can hear, the reach of the programme has been significant, and the scale of the programme has been significant. There are 2.475 women in the country, and our diversity and our needs are significant as well. So we're trying to bring that together, bring in our evidence base, which we've had through, you know, many clinicians, a lot of research that's been provided into the programme and led by the programme. Our consultation, which has been extensive, so we're trying to draw that in and again, you know, use criteria and try and assess, you know, those issues and make judgments on how to prioritise against those. We can see service metrics around pressures and gaps that we know we need to respond to. The government priorities around women's health are clear through the programme for government, so we need to make sure that the civil service is working to advance and implement those. We know, as you can see from our 2020 and 2021 projects and initiatives, that we've a job of work to do to embed those, to grow those, to make sure that they can become sustained and impactful projects into the long term. And then we have a bank of work. As I said at the beginning, the Women's Health Task Force doesn't operate in a vacuum. There's a long legacy of work to support women's health across the HSE and the Department of Health. We need to try and kind of harness that and bring it together as well. So, you know, our maternity strategy implementation, our work around cancer care and cancer screening, the introduction of termination of pregnancy services, the introduction of contraception. So we need to try and bind these things together into a programme of work that we know that we can manage and deliver. So that's our work for 2022. We hope to keep our focus on prioritisation We believe that's been a really powerful aspect of the programme to date, and should be a key theme of how we work going forward. Our ambitions for 2022 are to put the spotlight on some new areas that women are asking us to respond to, so to really make sure we have that responsiveness in our programme from the listening work we've done this year. We want to make sure that those core programmes are supported, are advanced, and are able to proceed through 2022 as they should. And we also want to make sure that we're leaving space to respond in 2022, so to listen to the new ideas that are out there, to try and capture the innovation that's in the system around good ideas that could make a difference, and to see if we can support those and grow those ideas where they emerge. So our 2022 plan will be trying to harness some space for that. And within that,
it's so, your work is so important, it's so essential. The thing that comes across when I'm listening to you right now, and I'm sorry to cut across you there, is just how all-encompassing and how massive it is, and how you really do need the support of so many other, departments. Are you all right if I just react? There's been a lot of reaction to you, so you're all right if I just go through some of these now.
Yeah.
I think we need more advanced midwives, practitioners, investment in midwifery at the clinical workforce. I'd really love to see nurses and midwives in roles around health promotion in primary and secondary school care. I agree with that, as well as mainly, obviously, to talk about sexual reproductive health care and education. What somebody said in response to something you said earlier, financial independence can be a real barrier for women taking control and being in control of their own health. That might be something that a lot of us don't actually think about anymore, which is absolutely valid. Super event, would it be possible to have a comment on transgender women and how their care needs are going to be met? If I could pass that to you, Rhona.
Yeah, so I mean, so much interesting comments there, and you're right, the scale of the programme is significant. So yes, we've spent a lot of time working with our directors of nursing and our directors of midwifery, looking at that nursing and midwifery workforce, trying to think about what role can they play in women's health into the future, building on the significant contribution they're making at present. So that's definitely an area we're going to keep focus and attention on. I really welcome the comment there around trans women, and I suppose I'd be so keen to make sure that we use the term women's health in this work. We use it as shorthand, and we intend for it to be a very inclusive form of work and a very inclusive statement. So absolutely. Absolutely brilliant. And I really want to encourage anybody who's with us right now or listening back or watching back later on to check out the Women's Taskforce, Health Taskforce online, and we'll put up all the links, and I'll share them on my own as well, because I do follow you closely across the year and think it's really remarkable. So thank you so much, Rhona, for doing that. Our final speaker this morning is Alana Ryan, National Women's Council of Ireland. And Alana, yesterday when I was going through your slides, I found some of all of it extremely fascinating, but a lot of things really jumped out to me as part of discoveries that you've made over the last year. You've worked in partnership, of course, with the Taskforce to report on improving health outcomes and experiences in the healthcare system for marginalised women. So Alana, I know you're going to do your own slides. We want to make sure you've gone into presenter mode and you're ready to go.
I think I am, Alison, but
thank you.
Maybe correct me if something goes awry. Absolutely. And thank you so much for having us here today. And it's just brilliant to be on a lineup with so many accomplished women who are doing such important work to improve access and experience of healthcare. So it's really great to be here. And I think just going back to the theme of the event, bias, it's important to say at the beginning that our experience of bias is far more acute if we're women of colour, if we're disabled, but depending on our sexuality or our gender orientation. I think, for traveller women as well, there's a real complexity there in terms of how society sees and gives opportunities to women. And this is why this research project was so important in terms of thinking about that Women's Health Action Plan and thinking about the future of women's healthcare in Ireland, that we are doing that in an inclusive sense. So, it was brilliant to be asked to do this research project, and it was something which we worked with Community Work Ireland on, and it's great to be able to share some.
sorry, Elena, you've actually gone on to mute. Sorry about that. There you
sorry.
go. We only missed a second. It's perfect.
Okay, perfect. So essentially the research project was run over the summer in partnership with Community Work Ireland. And it was really to flesh out our understanding of some of the barriers that we know groups of women in Ireland continue to face in access and experience of healthcare. So we knew from the Women's Health in Ireland evidence review that there were certain groups of women who continued to have poorer health outcomes and who are greater risk of poor experience of services. And we wanted to speak directly with those women to better understand what their needs were and hear from them around what an enabling and an inclusive system would look like. So the workshops were held on Zoom with disabled women, women of minority ethnicities, survivors of domestic abuse, and women living in disadvantaged communities. And women were able to self-select into whichever workshop that they felt best was most appropriate for them. And some women chose to go into a couple of different workshops, given the complexity of all of our identities and the fact that we can't just be kind of seen in neat boxes. Overall, we had 50 women take part, and there was a good spread in terms of urban and rural locations. 65% identified as white Irish. There were higher rates of unemployment and experience of poverty and disadvantage than in the representative research. So the radical listening representative research, which Rhona alluded to, was a really great overview of some of the issues which women nationwide are experiencing, but it was so important to be able to supplement that by understanding what particularly marginalised groups may have in terms of the challenges that they're likely to encounter. So a third were unemployed and a third were living in households where gross income was less than 40,000, and half were also providing care to children. And so what we found was very stark. I think starting with the positive, it was really clear that where local care was working well, it really provided a huge lifeline to women. It was seen very much in that preventative early intervention space. There was a real sense of solidarity and a trust, particularly where they were peer-led projects. So, the Traveller Primary Healthcare projects were cited as a really good example of peer-led support. Some of the initiatives that were happening in the family resource centres also really positively received, and local domestic abuse services too. And all of these things were, I think, presented by the women as kind of an antidote to navigating the complexity of the system as a whole. And as this woman said, it kept us all going. It wasn't even in the cooking, it was the talking to people. You had a friend and it was on Zoom, but they were still there. And she's speaking there about supports in a family resource centre. And I think it just shows how important these community-based community development work is for our health and our well-being overall. And I suppose part of the reason that was received so positively by the women across the 4 workshops was because when we started asking more detailed questions around experiences of primary care and hospital care, it was clear that there was still much work to be done to ensure that women were able to access care that met their needs and which worked for them. So, there was quite stark stories being shared around access issues for disabled women who are physically disabled, issues to do with interpretation or the absence of for women who have English as an additional language, challenges in being able to have a bit of privacy to discuss your health concern. And all of those problems were really exacerbating the health needs that the women were presenting with in the first case. So it was quite challenging to hear. So as this woman said about how she was navigating the system as a mother for her child, she said, "You are literally just told something is wrong with your child. Go figure it out yourself. You are thrown in a dark alley and you have to fight your way out. If you find a torch, fair play to you, but if you don't, you are going in blind." And again, I think that goes back to that sense of maybe helplessness and a need for better, clearer information on the care pathway and information which is accessible to everybody. As this woman of minority ethnicity said, "In my community, English is not their first language. It's hard sometimes when they go to hospital because some women, they need to go inside with their men, husband, boyfriend, whatever. they don't have freedom to talk. And I think that underlines that provision of interpretation and translation services isn't only important from a shared decision-making, doctor-patient interaction point, it's also really important for being able to create the space for disclosures and for identifying risks that women may be experiencing in their homes. So, you know, really underlining the importance of translation services there. And I suppose what came through here was really a resonating finding with the representative research that women are being underserved in some senses by a kind of feeling rushed or experiences being belittled or not feeling that their concerns were taken seriously. And going back to the point around bias, it was very clear that the women's experience of care for some women was really being affected by these overlapping inequalities. So gender with ethnicity, with age, with social class, and so on. So as this disabled woman said, going in my early 20s and saying to a doctor, sex is painful, and them saying, it's just the way you're built, nothing we can do for you. So again, you know, it is that bias there. In the survivors workshop, we also saw some tropes around the idea of the hysterical woman coming out again. And although some women did have very good experiences with GPs, others spoke about the need for GPs to have better awareness of what domestic abuse and coercive control looks like, and to be creating that environment for them to disclose and have support. As this woman said, I was forced to have a mental health check because I was seen as this absolutely crazy mother. They, the abusive partners, are very good liars and they turn the whole system against you. And the consequence of all of this was that for the women who did have successive poor experiences, and some women use the term gaslighting when describing their experiences, there was a reluctance to engage with the health system and other services, and in some cases women did withdraw, which is obviously very concerning. So as this disabled woman said, I get so anxious and so nervous anytime I go and see any form of medical professional now. And for a woman of minority ethnicity, it's really disheartening trying to navigate this, so much so that I refuse to see a doctor in Ireland. I haven't been back to a doctor, as you just get dismissed. So I think it was a really helpful project in terms of being able to better understand the barriers that are there for women in marginalised groups, and for us in the task force to really think about how we can build a better system which is more inclusive, which is more responsive to the diversity and needs. And so at NWC, we group these recommendations into 4 primary points. And the first one is really view women as equal partners. And if we are to be able to deliver against that, there are some really key actions that need to be taken forward. Women spoke about needing cultural competency training for health and social care staff, for training which was co-designed with women, which challenged some of those unconscious biases that we all have, and bridge the gap between the professional and the patient. And also, I think for some of the women, when they talked about what a good experience of care was and what, you know, an enabling experience was, it was care that was delivered by somebody who understood where they were coming from, who had that shared background. And I think that speaks to the importance of really having focused measures to improve diversity in senior leadership, so that our health and social care workforce is representative of the diversity in Ireland now. The second point was really going back to that positive finding around community development support and the role that these kind of preventative and early intervention spaces play, and, you know, really thinking about how GPs could tap into that local knowledge and be aware of what's going on in their communities, so they could maybe connect women with groups which are peer-led and which have been found to be helpful, and ensuring there's that smooth pathway between early intervention, peer-led support in the community, and more specialist help. Finally, it was around promoting accessibility and inclusion, so really clear messages around the importance of interpretation and translation services, the importance of thinking about the built environment and universal design, and also challenging us to think more about the kind of information that is given to women in navigating the care pathway, and thinking about how that might actually adversely affect women who don't have a university degree or who haven't advanced education, and how, you know, actually those materials may not be accessible. And finally, really we were kind of asked by the women to think about how this can be done as a cross-government piece. You know, women spoke very emphatically about the impact on their health of other areas. So for survivors of domestic abuse going through the court system, having to navigate that whole family court or criminal court proceedings, and the impact that that was having, there was a sense it really wasn't trauma informed, it wasn't responsive to their needs. For women in direct provision, there was a lot of issues being raised around the cramped conditions and you know, how in one case a woman had given birth on her own in her direct provision centre. There was a lot of recognition that actually across the board sexuality education, you know, hasn't equipped women with the knowledge they need on their reproductive and sexual health. And so it was really to kind of recognise that so much of this is a cross-government piece, and as the work of the Women's Health Taskforce progresses, we need to be thinking about a health in all policies approach across government. So it's been a great project to be involved in. A huge thank you to HSE Health and Wellbeing for funding the work, to Rhona and her predecessor Sarah Gibney for commissioning the research from the task force, and we're hoping to launch it now in the next few weeks, so there'll be far more detail in that. But any questions or comments, my email is there and I'm really happy to take any.
Alana, that's absolutely fascinating. It's just so important, and you know, yourself and Rhona and the work that you've done there. And I think the big thing that's come out of this whole, you know, the last hour and a half, 2 hours is just, it's about communication and it's about information and accessibility to that. And it is a huge collective effort. And a few of the comments coming in right now are lovely to read as well, just saying that I'm going to go off and think more about this. Everything that's been said today, I'm going to talk to my friends about it. It's about having conversations with your sisters and your wives and your friends, and just spreading information as best we can. I really, unless anybody else would like to add anything, we'd like to reiterate that the whole conversation, the whole panel, everything that we've done this morning is going to be available at bias/women/health.com, and you can always find out information at Bias Women's Health on Instagram and on Twitter as well. Dr. Geraldine Connolly, the Rotunda Hospital and Temple Street Hospital, started the panel this morning. We'd like to thank her so much. I found her talk so inspiring because, as I say, I'm a mother of a 10-year-old and we're getting into that area of our lives. Dr. Nóirín Russell as well, CervicalCheck, just driving home that important message of A, get your check done, but B, don't ignore any symptoms. And if you have those, go straight to your GP. Loretta Dignam, I'm as interested in your talk because that might be another phase of life that we're coming into. And I think it's so empowering and so wonderful. And Rhona Gaynor as well, Women's Health Task Force. I watch you guys, as I've just said, I repeated myself, but I watch you closely across the year of the developments. And Alana, Ryan, thank you very much. And to Emer, who set it all up, we thank you all for your messages as well. And it's been an absolute pleasure and honor to be part of this again. And I think that might be it. And thank you all for taking part. And I really, really appreciate it. And I hope you enjoyed watching this and attending it at home as well. And onwards and upwards.